So good afternoon. My name is Dr. Carla Shamblen. I am the Director of Clinical Education and an Associate Professor for the Creighton University PA program in Phoenix. So I want to thank you for joining us this afternoon during your lunch hour. We wanted to talk a little bit about some specific preceptor teaching strategies during this session. So we're going to jump right into it. I really kind of want to talk about, how to create an optimal learning environment, because I think that's one of the first things that when we think about teaching, we sometimes forget creating that space for students and communicating and setting expectations. How the different levels of the learner can affect maybe how we should tailor the educational experiences for our students on rotations. Talk about some strategies for teaching while maintaining your clinical efficiency. Obviously, you're very busy seeing patients and doing other administrative duties throughout the day. And then provide some examples of some tools that you can use. These are also located on our website. We have a Preceptor website for our program in Phoenix that you can find these things as well. So first off, I wanted to talk about, creating that kind of optimal learning environment and what that means. So obviously, we want it to be a positive learning experience for students in a positive learning environment. And with that comes, I think, just being, demonstrating almost. You're a mentor and a tutor. Demonstrating respectfulness to staff and to other colleagues and professionalism. Those are things that we express to our students are very important as part of the PA profession, and we want that to be modeled for them, as well as upholding ethical approaches to the care of patients, and again, kind of serving as a role model. We really stress cultural competency here at our program in Phoenix, so it's definitely something we would like to see our preceptors also demonstrating, and then maintaining professional boundaries. I think sometimes we want to be that friend with a student. We offer them to take them to lunch or dinner or come to our house for an evening for drinks or things like that, and we really want to make sure that we're maintaining some professional boundaries there and not engaging in those types of activities. I've also had some preceptors in the past that have, asked for personal favors to be done, such as, taking up laundry or taking their child to school. So things like that we want to avoid, obviously. But also, back when I was a student, there was a lot more, I think, acceptance of being pimped as a student on rotation by your preceptor. Often you might have felt belittled in front of other peers, other students on the rotation. And I think we are getting away from that. But again, that's something that can really taint the environment and make for a negative experience for students. So we want to find ways and give you tools to engage in students and have discourse and questioning, but without them feeling like they're being put on the spot or maybe embarrassed in front of other staff or providers or other students on the rotation. So some strategies to ensure student engagement. First, I think it's really important to be aware of the level of the learner that you have. Our rotations are over the course of 16 months. And so students who are on their very first rotation obviously are extremely nervous, very, very green, very new to the whole experience of what it's like to be in clinic or hospital setting. And also, just being on a clinical rotation and what's expected of them as a student. So I think being aware of where they're at in their learning is really important. And also recognizing a lot of our students as PAs, students come in with experience. So they have a certain number of patient care hours that they've probably obtained by working either as a CNA or a medical assistant or a scribe in the ER or various doctors' offices. And so they do come a lot of times. We even have a nurse in our program currently. So they come with a lot of experience prior to school, but also, again, depending on where they are in their clinical phase, you want to kind of gauge what other rotations have they had thus far, what other areas of medicine have they been exposed to, because that might alter what you do on your rotation with them. We want you to understand that, patient encounters really are what we want our students to engage in, really trying to develop that clinical decision making. So really promoting critical thinking, working on clinical skills, so physical exam skills and procedural skills, and trying to, foster their confidence are really important. And then I often hear, preceptors tell me, well, I'm afraid to or maybe they're not precepting yet, and they're afraid to precept because they feel like, well, I don't feel ready yet. I've only been in practice for a couple of years, or I'm afraid they're going to ask me questions that I don't know the answer to. And that's okay. It's okay to not know everything. Or as a physician or a PA, we're not expected to know everything. We look a lot of things up ourselves. We're continuous learners, lifelong learners, and there's always change in medicine. And so I think it's okay to not always know the answer to a question they have. We want our students to develop these skills of being lifelong learners themselves. So encouraging self-directed learning, letting them go and do the research and then come back to you and talk about what they found and have a discourse or discussion about that topic or about that question that they initially had. And then there's opportunity for you to include some of your clinical expertise in that, and also just, I think, for you to learn as a provider, which is always important. So one of the things that I think is important when you're first kind of setting the stage when a student comes to rotation with you is space. So both physical space, but also creating kind of that mental or emotional space of, when it's prime time to ask questions or when you're going to give them direct feedback and things like that. Orienting them to the location that you're in, the setting, where the bathroom's located, where they can put their lunch, the staff, and introducing them to staff and other providers at your clinic. Going over expectations. And I think a lot of times, we only think of this as a one-way street. What are my expectations as a preceptor of the student? But oftentimes what happens is students will come in with an expectation of, they heard from another student what this rotation is like, or in their mind, they've just created this idea of what the rotation will look like. And so they have their own expectations. And I think sometimes that's where miscommunication between the student and provider oftentimes is what leads to sometimes students feeling like they have a negative experience on the rotation, or preceptors feeling like they have a negative experience with a particular student. So I think setting the stage as far as what your expectations are as a preceptor, but also hearing what maybe the student is expecting out of this rotation, and either realigning those expectations or maybe seeing how you can help to meet those dependent on what they are. Just like that, going over objectives is important. We have objectives that are in the syllabus for each rotation. So making sure that you're clearly aware of what those look like, what the outcomes are for the student when they finish the rotation are, what they should be able to do. And then communication. So telling your students how they can reach you, whether that's providing your personal cell phone, and that the best way to reach you is by calling you, or maybe you prefer a text message, or maybe it's contact, the office manager or administrative person at the clinic or the site. So however you best want to be communicated with, and also obtaining from the student maybe their contact information, so that you can make sure that you guys can communicate any absences or issues that go on throughout the rotation. So again, space is a lot of times one of the things I hear as maybe a limiting factor to having students on rotation, an actual physical space for them. As far as the PA program and our accrediting body, our students are not required to have like a dedicated learning space for studying while on rotation. And so in terms of creating space for learning, I think it is important to have kind of an area that you feel you can tell the student, when you're not seeing patients, you can sit here. They may or may not provide, have their own laptop that they're bringing with them to clinic, or maybe you provide those things for them. And then, letting them know sometimes, they're joined to your hip every day for 8 hours a day, and letting them know that it's okay, like as a provider, or just today, I need to be able to have some time to myself to enjoy lunch by myself, or make some phone calls that are personal or things like that. And letting them know when it's okay to not be constantly with you. I think sometimes that's hard for a student to know because they're so eager to please and they're so eager to learn and want to be near you. And sometimes you need to create that space away from them too. I think it's important too to, like I said, talking about when is the best time or space for teaching and learning. Like, when would you like for them to ask questions? Do you want them to ask questions in the room when you're seeing a patient together, or do you want them to wait until you come out of the room and you're in the hallway or you go back to your office? Maybe it's, at lunchtime, you want them to hold their questions and talk to you at lunch about questions. So I think just kind of discussing that and in your mind already kind of developing before you get a student on rotation with you, what that looks like for you, what is going to work best given your schedule and the setting that you're in. So how do we incorporate students into a busy schedule? That's always like one of the big things that I hear from preceptors as well, or wannabe preceptors. And I think sometimes we have the mindset that we think students have to see every patient that's on our schedule, and that's not the case. So a lot of times what you can do is look at your schedule in advance for the day and pre-select patients that are coming in based on their chief complaint or based on your own knowledge of how those visits typically go. Are they an easier patient to deal with? It provides a pretty logical, history for you every time, versus somebody who maybe is a little bit more difficult for a new student on their very first rotation. So picking those patients ahead of time and letting the student know which ones you want them to go and see. Also considering, adjunct activities. So they don't have to just be seeing patients. There's a lot more to medicine than that. And so having them do things like assisting the medical assistant with getting vitals or doing blood draws in the office, maybe even spending part of the day or a few hours with front office staff to see what that looks like in a clinical setting if they've never been in an office setting before, of kind of the day-to-day, or with a billing, if you have billing on site, kind of coding and billing, that can be an important tool as a provider to learn as a student. So you can kind of adjust what they're doing on a day-to-day or week-to-week basis so that they're getting exposure to these things and you're not feeling like they're burdening you and your ability to see patients from morning to afternoon. Factor in time for teaching and feedback. Again, this is really important to maybe tell the students, I think it's easier for me to discuss with you or give you some feedback about how yesterday went tomorrow morning, right before we start seeing patients again for the day. Or maybe it's at the end of the week, we'll kind of go over highlights of things that I thought you did really well, or some things I'd like you to work on before next week. So I think finding time and factoring that in is important when you are thinking about how you're going to incorporate a student into your schedule. As far as orienting the student and providing expectations, so again, orienting them to the practice. So not only the physical building, but also kind of how you run your practice in terms of what to do if you need maybe an in-office lab done. Who should the student contact? Which MA works with you? As far as referrals, what is the process for that? Where can you find patient education? So kind of orienting them to how you run the practice day in and day out. Also preparing staff for the role of the student and what you anticipate or expect the student to be doing on their rotation. I think it's important to educate your staff about that so that they are willing to go grab the student when there's something that needs to be done that they know the student is capable or that you feel like you would like them to do, but also not burdening them with things that may be unnecessary, such as more administrative type duties that are not as not important, but not as vital to their learning as a provider. It's also important to inform patients and to obtain their consent for students to be involved in their care. And there's different ways you can do that. You can ask them verbally. Certainly, we tell our students that they should be entering every room with a patient, identifying themselves as a PA student, and asking if it's okay that they see them. for their visit. But also you can post something in the front of your office if you regularly have students at your clinic saying that you are a teaching facility and that patients can expect to see students, and if they prefer not to, just to let you know. You could post something in the room as well, just a written form. But really, I think most of the time verbally is probably one of the easiest ways to just ensure that patients are informed and okay with students being involved in their care. I also think part of the orientation process for students should be to share kind of your history as a preceptor. You know, is this your first time? And so maybe you're wanting feedback from the student about what they liked about the rotation and what you did well, what they could incorporate next time. Or maybe you've been a preceptor for many years, and so sharing with them kind of the things that you've done or the things you've seen over the years that have worked well and what your teaching style is kind of like. Our students are really adaptable. We ask them to be flexible from day one. And as a PA, I think that's really kind of one of the pillars of our profession is being flexible and adaptable. So as they move from one rotation to the next, or they work with different preceptors and providers, we expect them to kind of adapt to their teaching styles and to their desires or their wants or their expectations. So just sharing that with them, I think, is a great way to orient them as well. Again, consider the level and pace of the learner in terms of the things that you're allowing them to do or wanting them to do. And then delegating increasing levels of responsibility. So as you're seeing, you know, maybe it's a student on their first rotation or second rotation, maybe the first few days or week are primarily them observing you and kind of following you and getting used to how the clinic runs and how you interact with patients and how you do things, your EMR system. And then as you feel comfortable, allowing them to start, you know, taking histories and doing physical exams and presenting to you. And certainly I think this would look very different if it's a student later in the rotation series. They may come in and off the bat, you know, first day you ask them to go in and take a history and physical and give an oral presentation back to you. And you give them a time limit of, I want you to, you know, in 10 minutes, go do that. So delegating increasing levels of responsibility, is really important, I think, based on your perception of how the student's doing on the rotation, also where they are in terms of their level of learning. So objectives, again, our syllabus has specific rotation objectives in there. Really, we're just looking for you to have an idea of kind of how kind of what kind of exposure in terms of breadth and depth that we're looking for on the rotation for students. And then also, you know, what things we expect the students to be able to do at the end of the rotation. So we usually refer to those as learning outcomes. And that typically is what's on their evaluation when you complete the evaluation at the mid and end. Again, reviewing the students' goals. If it's maybe it's a student that's already had a women's health rotation and they didn't do as many pelvic exams as they would have liked, and you're now in a family practice setting and you see a lot of women's health, maybe that's something that, you know, they've expressed to you, I really want to go into women's health, or I really enjoy it, but I don't feel confident yet in my skills doing pelvic exams. Then I think trying to identify again those patients on your schedule or that would be appropriate for the student to be able to try to reach the goals that they have for themselves on that rotation is important. We do have evaluations that we ask that you kind of review what it is that we're looking for the student to be able to be competent in at the end of the rotation, and looking at the beginning of the rotation, and then reviewing the evaluation with the student is important, but also they're going to evaluate you and the rotation site. So I think knowing what you're going to be evaluated on is also sometimes helpful. I know that when I do lectures and I'm getting peer reviewed by one of my colleagues, it's nice to know what it is that they're looking for and what they're evaluating me on when I lecture. And so just as easily as you can take a look at what the evaluation looks like for you, just ask us for that. We're happy to share it with you. And then you'll kind of know what's being evaluated of you by the student at the end of the rotation. So let's talk about some strategies on how to maximize time. Again, students do not need to see every single patient that you see. They also don't need to see every patient from beginning to end of the visit. So you could rotate tasks, you can work together, go in and see a patient together. Perhaps you act as the scribe while, in the EMR chart, while the student is taking the history and doing the physical exam. But you can kind of rotate those tasks. You can give the students time limits. Again, maybe it's a very new student. You're going to give them a little more time to gather a full history on a patient that's maybe a new patient versus someone who's been on several rotations and it's an established patient. So you're going to say, go in and take a history and give me a history report in the next 5 minutes. Students are a little bit slower, right? And that's okay. But we also know we have patients that like providers that spend time with them and providers that have the time to sit and talk with them, to hear their stories. And so utilize students to see those patients. I've always found that that's a great way to let the student learn also how to manage an encounter like that where they have to get key information, but maybe it's a little more the patient can be tangential or it can be a little bit more difficult and they have to figure out how to navigate that. So feel free to utilize students for patients that like extra time with you. Again, scribing for the student is one way to maximize your time, so that if your EMR system doesn't allow for students to actually put notes in there, you can be doing it while the student's doing the encounter rather than having to wait and put it in afterward yourself. Have students look up questions that come up during the day and then share the answers with you. I'm going to talk a little bit on a couple of slides after this about wave scheduling, but that's a way, if you have the ability to adjust your schedule or work with your practice administrator to adjust your schedule, we can show you how to do some different bookings that will allow you to see the same number of patients in an hour, but you're seeing some of the patients and the student is simultaneously seeing some of them. And then again, having students perform ancillary services or activities with other staff kind of can take some time off of your schedule, but constantly having a student with you. So here's the first example of wave scheduling. So if you're seeing patients every 15 minutes, you could double book that first appointment at 8 o'clock and have yourself see one patient while the student sees the other, or patient B. And then by 8:15, when you're already done with your first patient of the morning, you can go in and finish up patient B with the student. And then you do the same thing moving into the 8:30 and 8:45 time space spots there. And so you still end up seeing 4 patients in an hour, but the student has had the ability to see 2 patients and you've overseen and supervised those visits as well. That's the first example. There's another example of wave scheduling where maybe you just give the student a little bit more time. So this might work well for a student who's a little bit earlier in their rotation phase. Again, you double book your first appointment at 8 o'clock. So you see patient A while they're seeing patient B. And you actually give them about half an hour for patient B while you go and see a second patient yourself, or the third of the hour at 8:15. And then you finish up patient B with the student at 8:30 and then move on to your patient D at 8:45, and it just kind of goes on from there. So you can see where if you have this ability to adjust your schedule, this is a great way to incorporate students into the day without impacting your productivity and your patient schedule. There's a lot of activities that you can have students do as well that are somewhat ancillary, but providing kind of pre-visit planning. So if you have somebody coming in for a wellness exam, or maybe they're a more chronic patient coming in for their regular, 3 or 6 month checkup, you can have the student look through their chart in advance and determine, maybe what preventative services are needed based on their age and their risk factors or what they've had done already, maybe what labs are needed to be ordered at this visit, what their last labs look like when they were performed. Another thing that's a great way to utilize students is to perform medication reconciliation. The students need just as much practice, if not more, with medications and pharmacology. And so that's one way for them to kind of also make sure that your information in your system is current and up to date with what the patient is taking. Giving immunizations, performing blood draws, these are all things that our students will do in their didactic phase before they get to you on rotation. So letting them kind of participate with the medical assistant or the nurse in performing these procedural skills will give them, again, more exposure to it, more confidence in their ability to do it, and it will allow them to have that still continuous kind of patient interaction that we're looking for. Having them give patient education, they need practice on this as well. So you can certainly, once you've finished with a visit, if you feel confident in the student's kind of knowledge and ability, letting them provide the patient education on that particular case. Maybe finding, really quality educational materials for your clinic or office that they could then utilize, or that other providers can utilize to hand out to patients as a way to provide patient education. And then communicating lab results to patients. Again, this is a skill that comes with being a provider, but you need practice in doing it. So as a student, communicating results that are both normal and also abnormal, and what needs to happen next, whether that's maybe the patient needs to be prescribed another medication or an antibiotic based on the lab results, or maybe they need a follow-up visit or they need a referral. So figuring out how to have those conversations with patients is a great way to allow students to participate, but also take some of the burden off of you in terms of administrative duties. So communication, I mentioned before, I've been a director of clinical education for PA programs now for 10 years, moving into 11 years. And whenever I do have either issues with students that are on rotation and preceptors are having difficulty with them, or the student is struggling, or I have students who maybe provide comments during the rotation or after the rotation on their evaluation about how they felt the rotation went, that are maybe have more of a negative tone. Whenever I end up talking with both students and preceptors, the majority of the time, the underlying kind of theme is miscommunication. And so I want to stress that this is something that's really important as a preceptor. So again, communicating what your expectations of the student on the rotation are, being very clear with what the schedule is and what your requirements for them are. We don't dictate their schedule. We allow them to work the preceptor schedule, whatever that looks like. And that includes, on-call hours, evenings, weekends. We just ask that you give them the time off rotation for holidays that we observe as a university. So just making sure that the student knows what's expected of them in terms of hours worked or days worked or schedule. And then any assignments. So if you give them any assignments, you're more than welcome to do that, and just communicating what your expectations are for those things. I think we're going to have a separate session on providing feedback, but one of the things I can't stress enough is giving concrete illustrations to students. And I think it's important with feedback also to tell them things they're doing well, so giving them positive reinforcement so they keep doing those things, but also giving concrete illustrations of ways that they can improve, or maybe different ways to do things is really helpful for them in their learning. I think giving students, permission to ask questions is important. And again, it's okay to tell them that this isn't the ideal time. This is when I'd like you to ask questions, hold them till the end of the day, or let's talk about, the morning session after lunch, and then we'll reconnect again at the end of the day with any questions you had for the afternoon patients. And then communicating any circumstances that could interfere with the goals of the rotation. So maybe that looks like you have a planned vacation during the rotation and you need them to work with another provider, or maybe the patient census is different because of the time of year, and you're concerned they're not going to see all the things they need to for this particular rotation to meet the objectives of the learning outcomes. Then I think communicating that with the student, providing maybe some case studies or additional assignments, or communicating with the program so that we can then try to make sure that the student's able to achieve what they need to for the rotation to be successful. So those are kind of all the ways to incorporate students, and I think kind of best practices for orienting them to the to the practice setting and to your expectations. And now I want to jump into some actual teaching methods and styles. I don't know if we want to just wait for questions till the end, or if now is a good time to, I see there's maybe a couple things in the chat here. Let's see. Oh, maybe not. Okay. So if there's no questions at this time, we'll just wait till the end. All right, so specific teaching methods and styles. There we go. I like to think back to when I was a student and, what it was about certain teachers that I had that made me really like them or really feel like I learned from them, found it, exciting or engaging. And so I would just ask you to recall a time when you were a student, and kind of what methods did your preceptors use when they were teaching, and what was effective, what was helpful. And then also think about, if you're currently precepting, how would you describe your teaching style currently? Do you feel like you have a teaching style? Maybe you don't, and you want to develop one, and that's okay. So one of the first methods I would say is overly utilized, because we often feel burdened as providers to get through the day, get through the schedule. And so observation, this is definitely something that you can learn a lot from, but I would say it's something we want to try to minimize as much as possible, because it is primarily just passive learning, and we want our students to be engaged and doing active learning. So it could be observation or modeling. So there's something called the TAPS method, which is where you as a provider, as you're doing things, you kind of think aloud about why maybe you're selecting a certain medication and writing a prescription. You would be talking through that as the students just kind of listening and standing there with you, and they're kind of learning from your clinical reasoning and problem solving. You might be asked a lot of why questions during this type of kind of modeling or observation. So if that's not something you want, or you feel like you don't have time for a lot of questions, this might not be the best method for you to use. And again, I think a lot can be learned from passive observation, but we really want our students to be involved and active. So I want to share some other strategies for you. As far as coaching, which is the next one, this is really good for procedural skills. So kind of providing a verbal clue as the student is actually performing the procedure. So you can either prime them in advance and kind of orient them to the case and how you want them to do things and how things should go, and then kind of give them step-by-step kind of encouragement and verbal clues as they go throughout the procedure. This is great, obviously, for surgery rotations and other rotations where there's a lot of hands-on procedural skills being performed. This is probably one of the most utilized and well-known types of methods for teaching, and it's case presentation. So this is kind of what I was talking about earlier on, where the student would go in and take a history and perform their physical exam. Probably it could be with you in the room, but most of the time without you in the room. And then you would have the student come out and present to you outside of the exam room the case. The purpose is for them to be able to kind of retrieve that information on their own, and then summarize it in a very succinct way for you that is clear and logical, and then provide that opportunity to then start having some clinical decision making about what they think is going on, and discussing with you management and things like that. But probably one of the most utilized and one of the most familiar as far as methods. Then there's direct questioning. And again, this could be utilized in combination with case presentation. So asking the student specifically, what do you think is going on? And then tell me, why do you think that? Give me your rationale for either for or against those differentials that you're providing me, or why you did the specific physical exam, or why you didn't do maybe something. So it can be a nice way to, again, kind of complement the case presentation type of modeling or method. Again, it's really kind of informative to understand whether a student is just totally, memorized something and doesn't have the ability to think through the process versus do they really understand it to a deeper level? Can they apply it? Can they apply it to different cases? And what is their understanding? And so I think direct questioning a lot of times unveils sometimes gaps in students' learning and understanding of things. And that's where you as a provider or preceptor can then provide them with direction or additional resources or assigning them to different, patient encounters that would help to improve that knowledge. There's something called the 1-minute preceptor, which you may or may not be familiar with. It's another really great, quick, on-the-spot way to kind of teach students on rotation. So as they do their case presentation, when they finish up with you, kind of get a commitment from them of what the student thinks is going on with the patient. Then you as a preceptor would ask for, again, supporting evidence or rationale as to why the student thinks that. Then this is an opportune time for you to kind of give them those little clinical pearls that we always talk about, and you can kind of teach them a general rule about that specific case or disease or condition. Again, reinforcing to them what they did well, and then correcting any errors that you saw or that you noticed. So this next slide kind of goes into that a little bit more. If you reach out to me, we have these on little cards that you can put in your pocket if you can't remember kind of the 5 steps. But again, it's called the 1-minute preceptor because it takes about a minute to kind of go through these things with them. And it's a really great way to determine the student's level of understanding, to teach a clinical pearl, to reinforce or give that positive feedback, and then to correct any mistakes for the next time that you want them to improve upon. There's also something called the SNAPS model. Unfortunately, the SNAPS model is a little bit more, I would say, student driven. So the student has to be a little bit aware of it. You could share this method with them at the start of the rotation if it's a model that you like and a method of teaching that you like. It's pretty easy to follow. So they would, again, they would do the history and physical exam of the patient, come out, present to you, summarize the case for you, and then narrow their differential. Kind of analyze the differential. So give you reasoning as to why certain conditions or diseases are on that differential or are not, or maybe where they're at on a differential, the top versus the bottom. And then they would probe you for any questions they have about the case. So kind of lingering questions, or maybe they're feeling indecisive about a diagnostic test they're thinking about ordering and whether they should do that or not. So they would probe you for any information that they still have. And then together, kind of the student would develop a management plan, discuss that with you, and then select an area that they want to do some additional self-directed learning on after that. So again, it's more student-led, but it is a great way to encourage self-directed learning and to really understand if the student can rationally think through and critically think through a medical encounter with the patient. This is a pretty easy method. It's called ask, respond, tell. So I think it's very similar to we always called it the sandwich method, which is like you give some positive feedback and then you give a little bit of something you want the student to do differently next time or that they could improve upon, and then you end the conversation with some positive feedback again. So similar to that, but it's called ask, respond, tell. So first you would ask the student, what they thought went well during the patient encounter or what they might do differently next time. Have them engage with you. Respond to them by telling them, maybe it's reassuring them, I understand that you felt overwhelmed because the patient's problem list was long and you only had 10 minutes in the room to do everything, and then kind of giving them some guidance on what they could do in the event that happens again. So again, just kind of providing some mentoring, if you will, to the student, or redirecting them on how to do that particular encounter a little bit differently next time to have a better result. So the specific one, they're saying, you know, instead of attempting to address all the problems in one visit, then work collaboratively with the patient to prioritize maybe the agenda for that day's visit, and then letting them know they need to come back and see them again for the other conditions or other issues they have. So in case of the struggling student, I think, again, communication is really important. So just contacting the program as soon as possible. And really this is because we don't expect you to take on the burden of improving the knowledge of our students necessarily. There's other things and resources that we have here on campus. There's extra time that we have as faculty that we can meet with learners outside of the rotation hours without it being burdensome to you. So certainly reaching out to us, and we will develop kind of an action plan based on your feedback and the students kind of concept or feedback of what's going on in the rotation. And we'll work with them individually. And that may be going over cases together. It may be giving them certain assignments. It may be meeting with them weekly for various things. But certainly we can provide that feedback and mentoring and additional kind of knowledge checks and things. And don't feel like that's something that you have to do for a student that's struggling on rotation. So please just reach out to us. We're more than happy to engage and work that out with you and come to some kind of action plan and goal for what we want the student to be able to do by certain time frame in the rotation. We don't want to wait till the very end and have the student be potentially failing the rotation because they couldn't meet the learning outcomes, not knowing that they were struggling kind of all along or what they're struggling with. So
Carla, on this slide, will you just go back one on the action plan? Somebody is asking, is the action plan on their permanent record as a student? Would there be a problem with the communication of remediation?
So not at all. So the only thing that would go kind of in their student file in terms of if we actually have to um, remediate them formally. So if we have a student who fails a rotation, then they're going to need to remediate that rotation. Or if they are unsuccessful in meeting a learning outcome on the rotation, but they passed the end of rotation exam and did everything else, they need to remediate that learning outcome and show us that they're competent. And so whenever that happens, it's something that I do with them. I meet with them and we figure out a way of how we're going to remediate. We develop a plan. And that would go into their student file, but more for academic reasons, not anything that is punitive or even really visible to like licensing boards or things like that. What the licensing board would see is if they actually failed a course that they've remade it, made it up again, but they don't actually see the actual plan of everything for remediation. For students that are just struggling, maybe you're concerned partway through the rotation that they're not doing well, they're not at the level of their peers that have been on rotation with you already. Certainly those are just things we do. I mean, we do that throughout the didactic year too. We work with students who are struggling, and that doesn't go into their permanent record. It's not anything that's visible to anybody other than internal faculty. Does that answer the question?
I think
Hopefully.
so. Thank you.
Oh. Again, some of these resources I shared as far as teaching methods are on our Creighton Phoenix PA program website. There's also a really great resource, the teachingphysician.org website. And then we have our handbook, which is posted online as well, that has kind of some of this stuff also just written in there in more paragraph narrative form, if you want to look at that at all. Certainly, if you have any questions ever, feel free to contact me. My office number's there, my email's there. I also am available. I'll give you my personal cell phone if you'd like. But again, we also have, I don't know if Darwin is still on, but we have some other faculty from the program in Omaha. So if you have questions, feel free. Darwin's been in PA education for more time than I have and has been doing this for a long time as well, as far as being kind of director of clinical rotation. So yeah, if you have any other questions, feel free. We still have time.